Assalamualaikum and hi to my lovely lecturer, Madam Karimah, and all my fellow friends. Today we will present a case study about nutritional management of Day 5 post-exploratory laparotomy for small bowel obstruction, secondary adhesions with ileocolic anastomosis. Before that, I will introduce all my group mates, which are Putri Nohanis, Alice Arisha, Farisha Erina, Nurul Aimi, Sharifah Radia, and me myself, Farah Izzah. This is our presentation outline, consists of 6 elements. So I will pass to my group mate to conduct this presentation.
Okay, so for patient's personal details, patient's name is Mrs. M and the age, sex and race of this patient is 60 years old, female and Malay respectively. Patients live in Dusun, Nyo, Terengganu, and Mrs. M is already married, but now she lives as a single mother with her daughter after her husband has passed away. For the diagnosis, which is Day 5 post-exploratory for small bowel obstruction, secondary adhesion with ileocolic anastomosis. The reason for her admission is because of she having abdominal pain with loose stool and able to place flatus, but has no episode of blood stain for about 5 days a week. She also vomit, colicky in nature, and loss of appetite in 5 days a week. Previously, she has been diagnosed with cervical cancer stage 2A, and she also has a history of went to the emergency department on 3rd of February 2020 due to abdominal pain and discharge with analgesic and anti-constipation medication. Type of the case is new case. For patient social background, Mrs. M is unemployed and has no occupation. She has SPM for her educational level and she was an ADL independent at home and ADL semi-dependent while in ward. There is no information regarding smoking history and alcohol consumption.
Okay, then we move to the medical diagnosis. This patient is post-diagnosed with a small bowel obstruction, which is a partial or complete blockage of the small intestine, which is a part of the digestive system. Okay, here are some of the main causes of small bowel obstruction, which are adhesion, Crohn's disease, malignancy, hernia. Okay, these are some of the risk factors, such as hernias, Crohn's disease, cancer, long-standing diabetes, and so on. Okay, for the diagnostic test, the patients will be asked about their medical history, then have some physical examination, and taken their blood test. In case they have fever, they may need other tests such as abdominal X-rays or CT scans. Okay, this is the summary of the disease. Initially, the patient has adhesion in small bowel due to laparotomy. Okay, then it caused the occurrence of obstruction in small bowel. The bowel prior to the obstruction become large, dilate, and filled with fluid and air. The patients will then have distension that caused by gas, aerobic and anaerobic growth, and by fluid, which are gastric juice and retarded absorption. The patients will then become dehydrated and loss of electrolyte due to reduced oral intake, faulty intestinal absorption, and losses from vomiting and diarrhea. The patients also underwent ileocolic anastomosis, which is the joining together of the end of ileum to the first part of the large intestine called colon. These are 3 different techniques used by the surgeons, which are end-to-end, side-to-side, and end-to-side, depending on the difference of the diameter of intestine. Okay, for the medications, this patient was given 10 types of drugs. Okay, this table shows the indication and side effect of each drugs. One of the indications is gastroesophageal reflux disease and history of erosive esophagitis. Okay, then 2 of the drugs are for bacterial infections, then deep vein thrombosis in abdominal and orthopedic surgery, ORS for diarrhea. Okay, then this parenterovide is for the vitamin B and C deficiency, especially after the surgery. Okay, then the T-lomotil for diarrhea, Citramadol for moderate to moderately severe chronic pain, MSKCL for hypokalemia, intravenous cephalosporin for infections.
Now, we'll be discussing about the nutritional assessment and interpretation of nutritional status, intervention, medical nutrition therapy, and monitoring and evaluation. Firstly, we'll look into the nutritional assessment, and this is the anthropometry data of the patient. We've calculated the BMI based on her weight and height, and her BMI was 26.37 kg per meter square, which falls under the category of overweight, and her ideal body weight would be 55.5 kg based on the BMI at 22.5 kg per meter square, while her ideal weight range would be from 45.6 to 61.3 kg at BMI 18.5 to 24.9 kg per meter square. Moving on to the biochemical data, the renal profile of sodium, creatine, and magnesium levels are below normal level, while others are normal. And for the full blood count parameters, they are all normal except for hemoglobin level, which is lower. And for the liver function test, lower albumin level was detected, which is due to the insufficient protein intake of the patient. Now, as for the clinical data, the patient has high systolic blood pressure, which is 152/72, while the IO chart obtained was negative, which indicates the negative fluid balance due to frequent vomiting and watery stools of the patient. The patient also receives 1 pint of normal saline per 24 hours. Alright, so this is the dietary data of the patient, and we have calculated the percentage of intake and requirement of the patient. Okay, so the patient energy intake was 1,265 kcal, which was lower than the energy requirement, and the protein intake was only 38 grams, which is equivalent to 12% only. And the patient also took tremendously high intake of carbohydrate by 80.6% and very low intake of fats by only 6.8%. And she also consumed high amount of simple sugar as shown by the diet history of 3 glasses of Milo per day. Moving on to the environmental assessment, the patient is a single mother as her husband has passed away and currently staying with her daughter at Dusun Yong, Terengganu. And for the functional assessment, the patient was ADL independent at home while ADL semi-dependent in the ward. The first nutrition diagnosis is inadequate energy intake related to loss of appetite as evidenced by diet history of 1,265 kilocalories per day. And the next one is the increased protein needs related to post-exploratory laparotomy and ileocolic anastomosis as evidenced by the protein requirement of more than 1.7 gram per kilogram body weight for gastrointestinal surgery. And the last nutrition diagnosis is excessive fluid loss related to frequent vomiting and watery stools as evidenced by low value of sodium, which was 133 millimole per liter, and negative IO value of negative 146 ml.
Okay, for nutrition intervention, these are the comparative standards for the patient. We calculated the energy requirement using 3 different equations, and we choose the energy from the Harris-Benedict equation, which is 1,852 kilocalorie with protein requirements of 110.5 grams per day. The macronutrient distributions are 24% from protein, 55% from carbohydrates, and 21% from fats. The short-term goals for the patient is to ensure that the patient have adequate of protein and energy intake to meet the requirements. And the long-term goals is to ensure that the patient are able to speed up the wound healing process. Our objectives and principles for this intervention of the patient is to increase the protein intake to meet the requirements by providing high protein diet. Second is to increase the energy intake by providing energy-dense foods and variety of food choices to increase the patient's appetite. For nutritional monitoring and evaluation, monitor the weight regularly to prevent from excessive weight loss, assess the biochemical data to ensure that they are within the normal value, review the clinical data such as the blood pressure and the IO chart, and assess the dietary intake of the patient and her adherence to the recommended diet to ensure that the patient have adequate energy intake to meet the requirements. And this is a distribution table. This is the examples of menu planning for weekday day 1. This is for weekday day 2. And this is for weekend.
Now let's see at the discussion part. So small bowel obstruction, or SBO, is mostly caused by adhesions, which is approximately 60% of cases. SBO is a partial or complete blockage of small intestines. The digested food will accumulate within the small intestine and cause colicky, and emesis. If it is untreated, it can cause strangulations that lead to ischemic and tissue necrosis. Usually, surgery like laparotomy will be done together with ileocolic anastomosis to treat small bowel obstruction. So after the surgery, post-operative care is needed, for example, high-protein diet. So now our goal is to provide adequate energy and protein intake. Mrs. M had low calorie intake due to low appetite. Patients with low appetite tend to eat empty calorie food with high sugar that can lead to weight gain. So energy-dense diet will help to increase calorie and avoid malnutrition to promote wound healing. Next, the needs of protein will increase after GI surgery. Current protein of Mrs. M is deficient, which can delay wound healing. So high protein diet will be implemented to promote wound healing process, thus increase albumin and creatine to normal level. So at last, the discharge plan can be proceeded after Mrs. M had reached adequate protein and energy intake. Post-operative protein requirements is range from 1.5 to 2 gram per kilogram of body weight. And next, malnutrition can delay wound healing and lower the defense against microbial infections. So early oral feeding, such as antibacterial medications, is needed to fight against microbial infections. Plus, a study states that early oral feeding after colorectal surgeries is safe and tolerated by patients. So after discharge, oral nutrition supplements will be given if needed. Patients with laparotomy will experience abdominal pains. Pain medication will be given to reduce the pains. And next, patient also needs counseling and nutrition recommendations prior discharge from dietitians. So usually the follow-up will take about 3 to 6 weeks after discharge for laparotomy surgery.
For the conclusion, we can conclude that nutrition management for this case study suggests a high protein diet and encourage the patient to finish all the foods with protein sources. Besides, provide the energy-dense foods with a variety of food choices to increase the patient's appetite. This is because the nutritional management aims to prevent malnutrition during the healing process. Therefore, we must monitor the patient weight regularly to avoid excessive weight loss after recovery. And thus, we have assessed the patient's dietary intake and adherence towards the recommended intake to ensure the patient achieves adequate energy intake and protein requirement. So that's all from us. Thank you for your attention.